the rheumatology. That course is very beneficial for, especially for the resident as well as private practitioner, because they all expert. They are the expert rheumatology. They did the very wonderful job, and they made the very conclusive slides and give the cryptic information for the general pediatrician as well as resident. Today's we have the 10th session. Today's we have the 10th session. So thanks to ma'am, and thanks to our today's speaker, my dear Dr. Pratap. Your previous talk was also very wonderful and very informative and very catchy talk. And thanks to our that program designer, Dr. Ajay and Dr. Anu, and all teams, Dr. Neha, they did the wonderful job behind that. They are the backbone for successful or the success of that program. So over to our president, sir.
Good morning, everybody, and a special welcome to Dr. Preeti Ganglani, ma'am, the Vice President of South Zone. So it's so heartening to see you in the morning in our IEP Delhi academic program. IIP Delhi has been an academic front for the whole country. We have been doing these regular e-master classes. We have already done last year in the field of endocrinology, hematology, and neonatology. And this year we started with rheumatology. And we have already launched the cardiology, pediatric cardiology e-master class. And I'm very happy to say that within 4 or 5 days of our launching this, we already received more than 100 registrations for that class also. So it's very interesting for all of us to listen to these talks. I'm a neonatologist myself, but listening to all the speakers and in this master class is really updating my knowledge. I'm sure that is happening to each one of us. Today's session is also going to be very interesting. Kawasaki disease is something which is very close to every pediatrician, because it's not possible that a practicing pediatrician has not seen a Kawasaki or its complication in its day-to-day practice. So with this, please, I request Dr. Preeti Ganglani ma'am to say a few words, and also introduce the speaker, Dr. Pratap Patra, for today's session. Dr. Preeti ma'am.
Thank you so much, Dr. Garg, for inviting me. And a big thanks to Dr. Sham, Dr. Anu, Dr. Neha, and Dr. Ajay Gupta for carrying this academic mantle forward. It's always a pleasure to come to Delhi because I did my undergraduation at Lady Hardinge Medical College. So it's lovely to be back home. Talking about Kawasaki disease, I'm really looking forward to your talk, Dr. Pratap. Today is Easter, so happy Easter. And I hope that we would gain some new insights into Kawasaki disease today. Kawasaki disease is the most common pediatric vasculitis, and I think it is also the most common missed pediatric diagnosis. And we know the cost of missing this diagnosis on its implications on the coronary arteries in almost 25% of the children who have Kawasaki's disease. Lately, there has been a lot of recent advances, and I hope, Pratap, we will learn more about these, the role of dysbiosis in Kawasaki disease, the role of microRNAs in Kawasaki disease, the association of Kawasaki disease with neurodevelopmental disorders like ADHD. Also, how do we diagnose Kawasaki shock syndrome? How do we diagnose macrophage activation syndrome? What are the clinical criteria? What are the lab criteria? And to top it all, what is the role of artificial intelligence in not only detecting Kawasaki disease, but also in treatment? So it's a pleasure once again to be here, Pratap, and I'm really looking forward to listening to you. And I'm so amazed that you are the additional professor in charge, Division of Pediatric Immunology and Rheumatology, AIIMS, Patna. Very, very distinguished speaker. Over to you, Pratap.
Thank you.
So we welcome Dr.
Yeah.
Over to you, sir.
Okay. Thank you. Thank you, ma'am, for the kind introductions. And I sincerely thank Dr. Ajay Gupta, Dr. Pankaj Garg, Dr. Anumaheswari ma'am, and Dr. Meena for giving this opportunity to speak on Kawasaki disease. And my slides are visible, sir?
Yeah, they are visible. Do it in full screen.
Yeah. And Audio is also okay?
Yeah, audio is also fine. But yeah, thank you. Very well said.
Okay, sir. So we'll go ahead with the presentation of today's session, that is Kawasaki disease. And as ma'am already mentioned, I should be discussing about many things from AI in Kawasaki disease to the biomarkers like microRNA. However, in these sessions, my focus will be on the based mainly to the clinical features and how we clinically diagnose Kawasaki disease and what is the recent guidelines. So uh, the Kawasaki disease was first described by Dr. Tomisaku Kawasaki in 1961. He was working in a hospital, that was Red Cross Hospital in Tokyo, and he saw a 12-year child who presented with continuous fever for 12 days, along with strawberry tongue, mucosal changes, cracked lips, and lymphadenopathy. So he described it is a condition, something distinguished from other condition that was most prominent at that time, that was scarlet fever. So the after that, the from India, it was much later in 1977. The first report of Kawasaki disease was reported by Taneza and colleague. And before 1990, from India, only 3 cases had been published or reported. These are the some important milestone that has been happened in the diagnosis of Kawasaki disease and management of Kawasaki disease. Dr. Kawasaki described his conditions in 1961. In 1962, he saw the another case and described it as a non-scarlet fever conditions. He also, in 1964, he reported and compiled the 22 cases of this Kawasaki disease. At that time, the terminology was mucocutaneous lymph node syndrome because there was features of lymph node enlargement and mucocutaneous features like strawberry tongue and dry cracked lips was more prominent in these children. In 1965, Dr. Noboru Tanaka performed the first autopsy in these patients. In 1967, Dr. Kawasaki compiled 50 cases of similar cases, and this was the first published in a Japanese journal named Arerugi. In 97, after that, there was a nationwide survey carried out on Kawasaki disease. The diagnostic guideline for diagnosis of KD and treatment was first published in Japan in 1970. Dr. Tanaka published an article linking KD and infantile polyarthritis nodosa in 1972. The first English language literature, it was published in 1974 in the Journal of Pediatrics. Dr. Hirohisa Kato, he did the first coronary artery angiography in these patients in 1970. Got placed in the Nelson Textbook of Pediatrics in 1978. So Kawasaki is the common vasculitis in today's era, and now the commonest cause of acquired heart disease globally in children. The diagnosis, treatment, and management guideline is provided by American Heart Association from time to time. The first guideline was proposed and published in circulation in 2000. This guideline has been updated in 2004 and 2024. The recent guideline has been published. The diagnosis of classical KD is not that difficult. Any child with fever for at least 5 days, along with any of 4 of the following principal features, can be diagnosed as Kawasaki disease. And also knowing that the mucosal changes like red cracked lips, strawberry tongue, erythema of the oral and pharyngeal mucosa is quite common in Kawasaki disease. In this patient, there will be bulbar conjunctival injections without any discharge. The rash that is seen in Kawasaki disease is microbial patients edema and edema of the hand and feet, along with periorbital dyschoma is quite common. That is seen in subacute phase of the disease. Characteristically, what is seen is the node enlargement is usually unilateral. So this was the diagnostic guideline that was proposed and published in 2017, and it was. However, this guideline has been changed in 2024, and any patients who is having fever for 4 days and
Pratap sir, I think your screen has frozen and your voice is also breaking. The screen is not moving.
Skin is not moving. Is it moving now?
No.
No.
Sir, the screen has come. Try move it. Yeah. सर क्लासिकल केडी डायग्नोसिस आ गया है, आगे मूव करके देखिए एक बार.
It is moving on my side.
I think आप बंद करके दोबारा शेयर कर लीजिए सर, ये इट्स मूव नहीं कर रहा है.
Okay.
हाँ जी.
हाँ, it's moving.
Now it is moving. हाँ.
Yes sir, please.
So in 2024 American Heart Association guideline, they have updated this diagnostic criteria. Any patients with fever for at least 4 days and any of the 4 of the 5 principal clinical features at any point of during the illness of the condition or these conditions can be diagnosed as Kawasaki disease, and all these features may evaluate our not but one thing as Kawasaki disease on day 4 of illness, the infection conditions should always be reasonably ruled out, and so there should be no alternative explanations. So these are some classical features of Kawasaki disease. So you can see there will be bilateral conjunctival injections without any discharge. The dry cracked leaves, also called it is KD leaves, is commonly seen. The rash that can be seen over the trunk and extremities, and this type of erythema over the extremities can be seen. This is the periungual desquamation that is classically seen in the subacute phase of the disease. Apart from that, other clinical feature that has been also helps in the diagnosis of KD is the BCG reactions, the periannual erythema with desquamations. This is also very characteristic of Kawasaki disease. Unless somebody proactively look for it, it can be missed. So Kawasaki disease not always present with complete features or typical features. They can present with incomplete features or with atypical manifestations. The or incomplete KD is the another term where the manifestations is atypical or all the features are not present. The atypical KD and incomplete KD is more common in young infants and should always be considered any child who is having fever more than 5 days, meeting less than 4 classical criteria. And in these children, the risk of coronary artery abnormality is very, very high. And one should, for the diagnosis, look at the compatible laboratory because all these patients are very high risk of developing coronary artery aneurysms. And high index of some suspicion is always needed to diagnose atypical or incomplete Kawasaki disease. So this is the flow to how to approach patients of atypical Kawasaki disease. So children with fever for more than 5 days, if they have only 2 to 3 of the clinical criteria, or any infants with fever for more than 7 days without any other explanation for if your inflammatory parameters like CRP and ESR is high, then look for anemia, look for the thrombocytosis, look at the albumin. There can be hypoalbuminemia. Look for the alanine transaminase, whether it is elevated or not. The leukocytosis, do there will be sterile pyuria, or do echo. There may be coronary artery aneurysm or dilations. If all these features are present, then go ahead with treatment. If all these features, after evaluating the laboratory test, your inflammatory parameters is normal, then you need to monitor the patients clinically and do serial laboratory evaluations. If fever persists, do echocardiography and monitor the patients and look for development of peeling. So this is the guideline that has been provided for the diagnosis of incomplete or atypical KD. So we'll discuss about a few cases that we have come across in our clinical practice. So this is a 17-month-old boy who was resident of Nalanda, Bihar, and he presented with chief complaints of high-grade fever for 15 days. There was history of redness of eyes for 10 days. It was associated with swelling of bilateral hands and feet. And he also had discommission of hands and crackling of lips for 6 days. The child received antibiotics initially for 5 days locally, but as fever was persisted, he was referred to another hospital in Patna, and where he was diagnosed as Kawasaki disease. The child received intravenous immunoglobulin 2 gram per kg on day 8 of illness, but his fever continued. For this, he also received the second dose of IVIG on day 11 of illness. However, he continued to have fever even after 2 doses of IVIG. So that's why he was referred to our center on day 14 of illness. So this was the image of this child. At this time, there was no dry crack lips because he has already received 2 doses of IVIG, but this type of polymorphous rash was present over the face and the tongue. The perineal discommission was not there, and there was no sublingual discommission. The echocardiography showed something quite significant. He had dilatation of all the arteries. His left anterior descending artery is this one you can see here in the echocardiography image. His Z-score is 13.8. So there was a giant aneurysm of the left anterior descending artery. Along with that, he had also dilatation of the both left main coronary artery and right coronary artery. So all the coronary artery had aneurysmal dilatations, and left anterior descending artery had giant aneurysmal dilation. On investigations, there was leukocytosis, thrombocytosis, and both inflammatory parameters were very high and sodium was low. This child was labeled as refractory KD and aggressive therapy was started. He was given aspirin at anti-inflammatory dose initially. He was also administered prednisolone, and infliximab was administered, and we also gave cycloferin. This child became febrile after 48 hours of admission. He was discharged on aspirin, that was antiplatelet dose 4 mg per kg, and for giant aneurysm, for the risk of thrombosis, enoxaparin was started. So learning point from this case is that infants are very high risk of coronary artery aneurysm, as in the index case had all the coronary arteries are involved. Delayed diagnosis infant is quite common, and refractory KD needs aggressive management with multi-pronged strategy. Moving on to the next case. This is a very interesting case that we saw 1 month ago only. And he presented with fever for 12 days. And he also had swelling and pain in the left side of scrotum for 7 days. The fever was very high grade. It was associated with the chills and rigor. And what was significant in this patient was there was a hydrocele. There was swelling on the left side of scrotum. It was sudden in onset and what is progressive. It was associated with pain and tenderness. However, there is no radiating to other side, and there was no history of trauma prior to this illness. There was no obvious focus for fever, and this patient had no other features suggestive of Kawasaki disease. On examinations, there was no lymphadenopathy. Other general physical examination were normal. This total examination revealed tenderness. The translumination test was positive, and gate above the swelling was positive, and this was suggestive of hydrocele. The systemic examination in this kid was essentially normal. His investigations revealed anemia, leukocytosis, thrombocytosis, and very high inflammatory parameters. ESR was 54 and CRP was normal. Both ALT/AST was elevated and sodium was low. So how we reached the diagnosis of Kawasaki disease in these patients? So the differential diagnosis that was considered in this patient was first was acute epididymitis. However, all points for this diagnosis was there was no diarrhea, urine culture was sterile, and fever was not subsided even after 10 days of antibiotic administrations. We also thought of torsion of testis, and for this ultrasound doctor was carried out, and there was normal blood flow. The cremastic reflex was also present, ruling out the diagnosis of torsion of testis. He was screened for all the atypical infections like strep, malaria, leptodengue, and viral fever and enteric fever. The tubercular workup was negative, and there was no hematological involvement. Even this child does not have any typical features of Kawasaki disease. His prolonged fever with increased ESR and presence of 4 of the laboratory criteria, the diagnosis of Kawasaki disease was made in this case, because there was anemia for us, there was thrombocytosis, and there was leukocytosis along with elevated alanine transaminase. So his diagnosis of atypical KD was made with testicular swelling, and echo was carried out. However, echo was normal in this patient. These patients received IVIG on day 7 of hospital admissions, and he received 2 grams of kg of IVIG over 8 to 12 hours along with aspirin. And you can see here there was total swelling that was prominent. On day 16, you can see the total swelling has significantly improved, and he's under follow-up. So learning points from these cases, accurate and early diagnosis can avoid unnecessary surgical interventions in atypical presentation of Kawasaki disease like hydrocele. Acute hydrocele can also be a clinical feature of Kawasaki disease, and up to 7 reports of hydrocele in Kawasaki disease has been reported worldwide. So whenever there is a diagnostic dilemma involving an inflammatory process, the Kawasaki disease should always be a potential differential diagnosis. Moving on to the next case, this was a 4-year-old boy who presented with high-grade fever for 7 days. He presented with unilateral neck swelling for 5 days. On examinations, he was febrile with temperature documented up to 104 degrees. Additionally, this child was extremely irritable, and he had tender cervical lymphadenopathy over the left cervical region. There was no evidence of BCG site reactions, and oropharyngeal examination was normal. So differential diagnosis of bacterial lymphadenopathy was considered in these patients, and he received IV antibiotics for 5 days. However, there was no improvement, and so what other investigation one should carry out in these situations? Any input from the panelist? This is a unilateral lymph node swelling, and patient is not responding to the usual antibiotics. What should be done next in these cases?
Should look for the PID worker.
Okay, PID worker. Okay. So We go ahead with investigations like complete blood examinations. He had anemia. He had total leukocyte count that is elevated. There was leukocytosis. The ESR and CRP was very high in this case. And we also carried out neck ultrasonography in these patients. And you can see there were multiple enlarged lymph nodes. They are uniformly hypoechoic, and there was well circumscribed margin, and there was absent of necrosis. Okay. And this patient was diagnosed as Kawasaki disease. This is very much characteristic of KD. This is also called cluster of grapes appearance of Kawasaki disease. So this is, if you bedside ultrasound examinations, this type picture is seen, then it is sure that is only Kawasaki disease. So Kawasaki disease at times, so this patient was finally diagnosed as KD and he received IVIG and given aspirin till afebrile, and his lymph node swelling gradually subside after 5 days of admissions. So key message from these cases is that the unilateral tender lymph node enlargement at times the presenting feature of KD. In these patients, some features of KD was noticed in the later part of the disease, and lymph node presentation, unilateral enlargement of the cervical lymph node, sometimes is the only manifestations and the presenting features of KD. That is called node fast presentation of KD. It is mistaken as infectious lymphadenitis. Ultrasonography is a very important tool that can demystify in the diagnosis of KD in the bedside. Lymph nodes are uniformly enlarged and they are hypoechoic without necrosis, and well circumcised margin and well visualized echogenic hilum, that is the characteristic of cervical lymph node enlargement in Kawasaki disease. Apart from this, KD at times present with KD shock syndromes, because in these patients, because of the wide stress vasculitis, there can be capillary leak and myocardial dysfunctions. This is most commonly seen in younger children, and those with delayed diagnosis, they present with hypertension and shock. So in these patients, there will be, along with clinical features, there will be very high inflammatory parameters, along with low albumin and very high BNP. These patients are usually managed with routine IVIG and steroid, along with inotropic support. KD at times also present with macrophage activation syndrome, although it is uncommon. So what are the clinical features? When you will suspect KD, the fever become continuous and there will be splenomegaly and hyperperitoneia. So if 3 of these features are present, then KD with macrophage activation should be considered, because it's a very difficult conditions, and aggressive therapy is required because mortality is very high when there is mass and KD is concurrently there. So primary therapy in patients with mass is corticosteroid. One can use cyclosporin and biologics like anakinra if available, but anakinra is very difficult to procure in India. And coronary artery involvement is also very common in KD with macrophage activation syndrome that should be regularly evaluated on daily basis. So the treatment of typical KD is very simple. One need to give IVIG that has to be infused over 8 to 12 hours, along with aspirin at the anti-inflammatory doses, followed by the antiplatelet dose. Then the aspirin at antiplatelet dose should be continued up to 8 weeks if there is no coronary artery involvement. So treatment of typical KD is quite simple, but there are many caveats in the treatment of Kawasaki disease, and these caveats make the treatment of KD so challenging. So what are these? IV resistance, the initial intensification when to use, and what are the additional therapy that are need to be used in the management of Kawasaki disease. So this is the cartoon showing the Kawasaki disease management. So any patients who made the complete KD criteria, one should start with IVIG and aspirin, and simultaneously it is very important to assess the high-risk features. High-risk features for development of coronary artery aneurysm. If any of the clinical features and echo features is there, if there is a dilatations, then one need to intensify the therapy. And one need to carry out regular echocardiography in every 2 to 3 days to detect underlying coronary artery aneurysm. In incomplete KD, the first line of IV treatment is also IVIG and aspirin, and also assess the high-risk features. Okay, and if the patient is suspected incomplete KD, and if you diagnose it is not likely to be incomplete typical KD, then follow up the patients and consider other diagnosis. If the patients with both typical and incomplete KD, they receive IVIG and aspirin and become afebrile after 36 hours of IVIG administrations, and the patient become afebrile, discharge the patients, transition to low dose aspirin, that is 3 to 5 mg per kg, advise the patient that no live vaccine should be administered till 11 months, and follow up these patients every 1 to 2 weekly for doing echo, because in first 2 weeks may not be there is evidence of coronary artery aneurysm, and provide KD education when to return to the clinic. So this is the recent guideline on the management of Kawasaki disease. Obviously, the standard therapy is IVIG and aspirin, but what they have mentioned in this guideline is when to intensify the therapy. And what are the drugs that is used for the intensification therapy? The most common agents are the prednisolone. Methylprednisolone also can be used. Infliximab and etanercept, both TNF inhibitors, also can be used for intensification of therapy. Apart from this, cyclosporin, anakinra, second dose of IVIG, and cyclophosphamide also can be used when there is a refractory Kawasaki disease. So when to do intensification of the initial therapy for high-risk patients? So this is basically the coronary artery aneurysms most commonly seen up to 20-25% in the children. However, infants younger than 6 months, they are at very high risk of coronary artery abnormality. And up to 43% of patients who are infant can develop coronary artery aneurysm. And it is very important to remember that even children, infant, at diagnosis did not have your coronary artery abnormality, they can develop these CAAs after 8 weeks later despite therapy. That's why intensification of therapy is very, very important in infants younger than 6 months. So this is a original article that is published from Chandigarh, and they have also mentioned that IVIG alone treating Kawasaki disease in infants below 6 months is not sufficient, and these patients should be given intensification therapy along with the IVIG option. So what are the additional therapies that has been recommended for the management of coronary artery aneurysm in Kawasaki disease? So statins plays a very big role. Statins is most commonly used in adults with atherosclerosis that lower the LDL cholesterol levels. But statin is also used in Kawasaki disease because it has many pleiotropic effects on the inflammations. It modulates the endothelial functions. It reduces oxidative stress. It inhibits platelet aggregations, inhibits coagulations, and promote fibrinolysis. So statins can be used in infant, so in children who are more than 2 years, and the dose is 0.75 mg per kg per day, and that is well tolerated. So for thromboprophylaxis, what should be used in these children? As you know, for coronary artery aneurysm, it is very important to prevent the thrombi. So we use aspirin initially with the antiplatelet dose, that is 3 to 5 mg per kg, and that is the mainstay of therapy. However, when a patient is diagnosed with large and giant aneurysm, where the risk of prostatitis is there, and there is chance of the thrombus formations, and there is activation of the clotting system. In these patients, anticoagulation is also required. So what are the most common anticoagulation that is required for the thromboprophylaxis is your low molecular weight heparin and warfarin. But in these days, the drugs like edoxaban and apixaban, there is the newer direct acting oral anticoagulants also used because it is very easy to administer. They do not require therapeutic monitoring and challenges that is posed by warfarin and low molecular weight warfarin. Because warfarin and low molecular weight heparin, you can frequent monitoring and dose adjustment. So direct acting oral coagulants can be used in this situation, but studies on these are only few case report and there are only anecdotal reports. So any patients with coronary artery aneurysm at diagnosis, so what should be our approach for the thromboprophylaxis? If any patient has a small aneurysm or medium aneurysm or has a large or giant aneurysm. So in addition to your IVIG and steroid, if the Z score of the coronary artery is 2.5 to less than 5, then single antiplatelet therapy is sufficient. So one can use low dose aspirin. If the Z score is more than 5 to 10, then dual antiplatelet therapy is recommended. One can use an aspirin along with clopidogrel. However, if the Z score is more than 10 or it is large or giant aneurysm, then dual antiplatelet therapy along with anticoagulations like low molecular weight heparin or direct anticoagulant agents is required. So this is the important difference in the guideline that has been proposed in the 2024 and 2017. So in 2017, the initial IVIG infusion was supposed to be administered about 12 to 14 hours. In this 24 guideline, they have mentioned that it should be given over 8 to 12 hours. Aspirin doses in acute phase of Kawasaki disease, previously 30 to 50 mg was recommended, and as high as 80 to 100 mg of aspirin was also used as anti-inflammatory doses. Now they have recommended the low dose of aspirin 3 to 5 mg per kg instead can be used because there is high risk of GI bleeding when this high dose of aspirin is used. Apart from that, in previous guideline, infliximab doses was 5 mg per kg over 2 hours, and now in this guideline they have mentioned that the infliximab dose should be used as 10 mg per kg over 2 hours. In both this guideline, there is no clear-cut mentions about the direct-acting oral coagulants, and still we are using direct-acting coagulants in patients where use of low molecular weight heparin and frequent dose adjusting is a issues. So take home today's message from this presentation is that KD is the most common vasculitis. Timely intervention is the important to minimize the risk of complications like coronary artery abnormalities. IVIG and aspirin is the standard mode of therapies. However, intensification is required, and one can use as corticosteroids or biological agents like infliximab and etanercept. Regular follow-up and cardiac monitoring is very, very important, and advice like on lifestyle adjustment also important for the overall well-being. With appropriate treatment, most of the children recover fully with no long-term effects. Thank you for your attention.
Thank you so much, Dr. Pratap. Over to Dr. Preeti ma'am for her comments, and then we can take some questions. Dr. Anu is here. Dr. Neha, they will coordinate. Yes,
Oh,
Dr. Preeti ma'am.
Thank you, Dr. Pratap. That was really a wonderful and a very simple yet elaborate discussion on Kawasaki disease. So easy to understand. I have a couple of questions myself. I was just wondering, why is Kawasaki disease more in the younger age group? And, being especially interested in adolescent health. So why not in the adolescent age group? Though I know that they are cases, and I myself have dealt with a case who was as old as 13 years old. So why is it more prevalent in the younger age groups?
Ma'am, Kawasaki disease, the etiology is not known, and it has multifactorial process. It is triggered by infections, and underlying genetic basis is there. Okay, ma'am. So environmental factors, infections, and underlying genetic factors contribute for the evolution of Kawasaki disease. And young children are more prone to infections, and they experience more infection in childhood. As they become adolescents or adult, the prevalence of infection also comes down. The possibility infections in this age group probably is the cause of higher incidence of KD in young populations.
Okay, thank you so much, Dr. Pratap. Another quick question. At what is the earliest age that you will start statins for these cases with coronary artery abnormalities?
Ma'am, it is safer to start after 2 years. It is after 2 years.
What is the dose and which statin would you start?
0.75 mg per kg per day, ma'am.
Which
Okay,
statin?
and that which statin?
0.75. Ma'am, atorvastatin.
Okay, okay, okay.
Atorvastatin.
Thank you so much. Thank you so much.
Okay.
Over to Dr.
Okay.
Anu and Dr. Neha. Thank you once again.
Good morning, Dr. Pratap. There's a question in the Q&A. Ki, sir, are the aneurysms reversible?
Yeah, mild and moderate aneurysm are reversible, but giant aneurysm takes quite long time, and one need to keep these patients on follow-up till they become adolescents and adults.
Right. Doctor.
Any other question, ma'am?
I think Dr. Anu, can I ask one? Hello, Dr. Anu, are you there? Dr.
Yes,
Pratap.
sir. Good morning, sir. Good morning.
So I think during the post COVID season, we got
Yes,
lot
sir.
of newborns who
Yes,
had
sir.
some multi-system involvement, inflammatory
Yes, sir.
disorders. And then there was a debate that whether it is a neonatal KD or it is something like
MISN.
ah. So does a condition like neonatal KD exist, or have you seen newborns presenting with the Kawasaki, or it is all post-COVID phenomena?
No, sir. There are reports of neonatal KD. In fact, in the last 2 months, we have seen 3 newborns with Kawasaki disease with echo findings. And sir, most of these newborns do have some underlying immunodeficiency. And during COVID, we saw an MISN like phenomena, which is multi-system inflammatory response in newborns. Basically, the mother is infected, and these antibodies from the mother gets transplacentally in the babies, and then they cause pathogenesis of this disease. In fact, we have published also young infants with MISN and KD like phenotype during the COVID. And sir, even after COVID, we do get, but sir, young infants more often, but newborns, I would say, in only in the last 2 3 months, which I'm presuming is because of that human metapneumovirus which had come in October, November. And after 6 to 8 weeks of that, that is in January, February, we got 2 to 3 newborns with Kawasaki disease with classical findings and echo findings, but they responded very well to the.
You're trying to say that the mother got metapneumovirus and the newborn got KD. That's what you're.
No, sir. That is during the COVID time. That is the
Okay.
mother got COVID. Mother had antibody response, and then those antibodies were transplacentally transferred to called MISN. That is
Right.
multi-system.
And what about metapneumovirus? How did
The
that?
human metapneumovirus peak was there in October, November, as far as I remember, because viral PCRs were showing human metapneumovirus and even RSV. So after that peak of viral illnesses, in January, February, we got a peak of Kawasaki disease, including 2 to 3 newborns, which I'm presuming is that in a post-viral state, when there is an immune dysregulation because of the viral infection, there is something that triggers Kawasaki disease in these children. Older children also, younger children also, but strangely enough, we saw a lot of young infants and newborns this time, which I was talking to Dr. Neha also,
Yeah.
that I think Dr. Neha has also seen quite a number of inflammatory myocarditis with KD-like phenotypes, sir.
So ultimately, Kawasaki disease remains a clinical diagnosis, and there
Absolutely,
are criteria.
sir.
So that means if you want to make another say criteria for diagnosis. There has to be a gold standard against which you validate those criteria.
Absolutely.
So what are those? So we always will be in a dilemma in a
Yeah.
one situation that this is KD or not. So how do you substantiate your findings or your case that okay, this is KD for sure?
Sir, KD, it's basically a clinical diagnosis, and lot of findings are very subjective. One clinician may say that lip cracking is because of cheilitis. Somebody may say it is because of micronutrient deficiency. But people who are attuned to looking at Kawasaki disease will know that this fissuring is not because of cheilitis or micronutrient deficiency. It is Kawasaki disease. So it takes certain degree of expertise and certain degree of experience. But sir, there is no gold standard as such except for the classical KD and incomplete KD criteria. But there is a recent surge in using anti-pro-BNP, which is anti-pro-BNP more than 500 in a child with consistent findings should be taken as that this is KD and it should be treated. So other biomarkers, seeing the complete picture, high CRP, neutrophil predominance, high platelet count, low sodium. In fact, GGT influenza, gamma glutyl transferase, increase in that in the absence of liver dysfunction should prompt us to think of KD. And anti-pro-BNP, sir, is coming up in a big way. Dr. Pratap, would you also like to comment on this?
Yes, ma'am, anti-probenectin can be used, and diagnosis of atypical KD is always challenging. Like
Yes.
in the case we discussed, the patient with hydrocele, everybody in our unit, including our HOD, they are saying that it is not Kawasaki disease, it can't be Kawasaki disease. But once we administered the IVIG and
Yeah.
the swelling disappeared, then everybody agreed, yes, it is Kawasaki disease. We are going to publish this case. Only 7 cases has been reported worldwide. And pro-BNP obviously do a supportive role in the diagnosis of KD, no doubt. But pro-BNP cost is also there. Many poor patients in
Yeah.
our hospital, pro-BNP costs around 2,000 rupees.
Oh
And
my.
poor patient, yeah, so poor patient can't afford to do this.
But still,
So
I think it is better to have some marker because I'm not
yes, yes,
saying,
better
but
to have some
over
marker.
over a period of time, we were underdiagnosing Kawasaki, but now I've seen we are somehow overdiagnosing also. I see a lot of patients who come to us for second opinion that this has been labeled as atypical Kawasaki and IVIG has been given, but there's no response. Now they are saying it's not the diagnosis. So overdiagnosis is also happening. So if there is some marker at least, even if it costs 2,000 rupees, not a
Sir,
problem. But
unfortunately,
IVIG is so expensive and it is being
Yes.
used without. I think if it's a typical Kawasaki, it should go to a rheumatologist. Only then we should say. And I see pediatricians also making a
Mhm.
typical Kawasaki, giving IVIG, then no response, and then they come back to the rheumatologist. So that type of practice at least should be there. Should be some target. Okay, if it is atypical Kawasaki, some target that okay, anti-pro BNP is so much, that's okay, or only a rheumatologist does it, something like that. I'm just suggesting because I see overuse of IVIG also in such situations.
Yes, sir. Sir,
You're
in fact, there
absolutely
is
right.
special. Sorry, Neha, you were saying something?
Sir is absolutely right. Even for pro-BNP, it is not a specific marker. It can be raised in infections also, sepsis also, in almost all of the
Yeah,
patients.
that is fine. But when you have a compatible clinical picture, when you're a little confused whether this
Talking about
redness is in
AD.
that setting, you can use. I'm not saying that you do anti-proBNP in viral infection and label as KD. No. If the anti-proBNP is more than 500 in a child with somewhat compatible features, should prompt you to think of Kawasaki disease. And we should do an echo in these children and not only look for coronary artery changes but other changes like pericardial effusion, valvular abnormalities, periarterial attenuation, and other findings are also consistent with KD, right? Not only coronary artery. So sometimes we do get children with pericardial effusion only. So that should also be taken in the setting of a clinical feature, and anti-pro-BNP should be treated like KD because not treating is going to be disastrous.
Right.
Pankaj sir, I'll tell one thing. It's better to overtreat rather than undertreat and have coronary artery aneurysms.
So the problem is that IVIG is an expensive drug. I have seen children, and I saw a child, I think few days back only, 40 kg child was around 6 years of age. He was given atypical Kawasaki label, given IVIG. That cost a lot of money also. So I'm not saying, I'm just a general pediatrician and neonatologist. I'm just suggesting that if it is a atypical situation, let a rheumatologist do it, not
Oh,
like
Yes,
a
yes, sir.
pediatrician.
yes, sir.
Yeah.
Unfortunately, after so many years of this description of the Kawasaki disease, unfortunately, there is no single biomarker that can tell it is KD or not KD, sir. That is a
Yeah.
problem.
So there should
But
be.
sir, anti-pro-BNP is quite promising, and we have seen that where we are confused when the findings are subtle, it does help in diagnosis. क्योंकि सर जो
Yes.
rash होता है ना केडी का, कई बार it is just like a reddish hue. So you don't understand that rash until you give IVIG and the color of the child changes. कि oh, this child's now the rash is not there, which may not be initially present. And sir, plus KD के जो features होते हैं ना, वो इकट्ठे कभी भी नहीं आते. The
Yeah,
like Dr.
sequential.
Pratap sir also said कि eye
Uh,
redness, if there is a history of eye redness during the illness and the child doesn't have it as of now, so you can't say कि अभी नहीं है. वो फीचर तो था और वो ऐड भी होगा, तो आप फिर 4 फीचर्स मैच करने के चक्कर में आई रेडनेस को मत ऐड करिए, वो ठीक नहीं है. So the
Correct, correct.
symptoms are in temporal relationship with each other. They can occur fleetingly and not at the same time. So history, subtle findings with the help of anti-pro-BNP and an echo. And like Dr. Pratap said, when in doubt, you can give IVIG safely and see for the response. If the response is not there, then rheumatologist should be consulted. And sir, आजकल तो Zoom calls हैं, video calls हैं. I get a lot of video calls also from doctors. Can you see this
See, the
Kawasaki
calls
disease?
comes once there is no response.
Yes.
That
Problem
is
comes
right.
and there is no response. Then because the other diagnosis are बहुत बार systemic onset JIA
They also get
Kawasaki
improved.
disease की
वो भी
तरह.
improve. IVIG is such a bullet therapy. Many
Yeah.
other disorders also get.
वो
Okay.
ठीक हो जाते हैं बच्चे.
Chalo, thank you so much. I think
Sir,
this
I
is
will
just an
send you the
observation.
newborn KD pictures.
Yeah,
आप
yeah,
देखिएगा उनको.
sure, sure.
Yeah, I will
So,
send them to you, sir.
okay,
Sir,
Dr.
I
Pratap,
had a
you.
question.
Hello,
Some other
Sorry, sir,
questions
go ahead.
also.
hello,
yeah, yeah.
hello. Thank you, Dr. Pratap. As usual, you nicely presented
There are
with
some more questions also, Sham.
Please. I was going
good.
to say that.
You
Dr.
nicely presented the good series of the cases. I have the some couple of the questions because nowadays, definitely Kawasaki is what I feel as a general pediatrician is quietly going toward the overdiagnosis. And you said rather than underdiagnosis, it should be overtreat. But that is a very difficult to manage, especially those are the older age kids because IVIG cost is major issues. So what are the other close differential diagnoses like the because scarlet fever is very close differential diagnosis of the Kawasaki. Infection mononucleosis is also quite common. So how you take that issues?
See, most of the viral infections and scarlet fever, that you can make a clinical diagnosis. So if it is scarlet fever, ASO titer will be high. The skin, there will be sandpaper rash. Okay, that will be prominent. And there will be pharyngeal infections. Okay. And so oral antibiotics definitely and ASO titer will be elevated in these patients. Apart from that, viral infection like Epstein-Barr virus infection.
सुशील ये म्यूट कीजिए जो भी है सुशील मिस्टर सुशील
What? Hello?
हाँ
Dr. Pankaj sir, ये
There
थोड़ा सा
there is some background noise.
हाँ डॉक्टर प्रताप प्लीज कंटिन्यू
So, scarlet fever, you can diagnose very easily. And ASO titer is very supportive. Okay. The rash that is seen in Kawasaki disease and scarlet fever is totally different. Okay. And they will have significant response to antibiotics in scarlet fever. KD will not have.
in continuation of that those are the atypical cases especially in the toddler age group before calling as a atypical Kawasaki it is mandatory to give the antibiotic trial because in your guideline they didn't say about that antibiotic trial.
Dr. Shyam, antibiotic would be given if there is a clinical indication.
No,
And
why I said if the child persists the fever more than 5 days along incomplete features of the Kawasaki.
So
Dr.
you,
Sham, oh, sorry, Dr. Pratap, please carry on. Yes.
okay, so you have to look the other features like if there is laboratory parameters, high SR, CRP, look at the sodium, look at the albumin. So if all these features are supportive of, then you can think of KD if the fever is more than 5 days and not responding to antibiotic therapy.
It usually occur in the also viral infection like the infection mononucleosis.
Infectious mononucleosis, there will be splenomegaly, there will be generalized lymphadenopathy. You can diagnose these patients very clinically. There will be pharyngeal inflammations, and there can be also rash in Epstein-Barr fever.
Okay, and you recently introduced the American Heart Association 2024 guideline about the atypical Kawasaki. They mentioned in the hematological parameter they added the anemia. So what is the
Anemia,
hypothesis
yes.
behind of that? Because in our setup, that the most of the children have the nutritional anemia. So
Okay.
that point is very difficult to taken up.
In Kawasaki disease, many cytokines plays a very important role. Interleukin 6 is one of the important cytokines that mediates the inflammations. It suppresses the hepcidin and it causes anemia.
Okay.
That is the reasons anemia is also has been included.
And what last thing from the my side, I request to all rheumatologists kindly highlight that things because that latest guideline in the American Heart Association 2024, they said we are the moving from the high dose to moderate dose to low dose. Because that we
Yes.
seen the lot of the adverse effect of the aspirin like the GI bleed, you already very well highlighted that issues. So that is a very important information. At least we should share with the general pediatrician. The dose is that is significantly reduced from the 80 to 30. Now the 32 we are the moving toward the less than 10 mg per kg. So that is an
Yeah.
important change in the recent guideline.
Yes, yes. Because high dose aspirin has many side effects like GI bleed, they can have tinnitus. Okay. And the risk of Ray's syndrome is also will be there. So they have had in meta-analysis that has been published in Oxford Rheumatology, and 3 mg per kg along with IVIG versus 30 to 50 mg per kg along with IVIG. And at the end of 4 weeks in this trial, there is no difference in the incidence of coronary artery abnormalities. That's why 3 mg per kg of aspirin at the acute phase of Kawasaki disease is also sufficient.
That is important change.
Yes,
Absolutely.
yes.
Okay.
Sir,
That-
there is one more
Sir,
question, Dr.
Yes,
Pratap sir.
yes,
Ye,
yes.
they're asking ki how long should DOACs should be given and how to monitor this. What should be the target INR while giving warfarin? How long should warfarin, LMWH, DOAC should be given? Any recommendation on monitoring those aneurysms?
Okay, so it is mild. All these patients with mild to moderate aneurysm, we regularly follow them every monthly initially. Then once there is regression of these aneurysm, we keep on follow up these patients every 2 monthly. And mild to moderate aneurysms are these likely to regress over time, where a giant aneurysm is maybe persist up to adolescent and adulthood as well. Regarding the thromboprophylaxis, says like your low molecular weight heparin and warfarin, the target INR is 2 to 3, but we prefer to maintain it around 2. And regarding direct acting oral anticoagulant agents, there are no studies, only anecdotal reports and case reports are available to date. And more studies are required on the role of direct acting oral anticoagulating agents. We in our series of Kawasaki disease, we have used only in one patient that he had bleeding from all the sides whenever he was taking low molecular weight heparin. So for direct acting oral coagulant agents, more studies or research is needed.
एक मिनट एक और क्वेश्चन है ये okay, this is fine, this you've answered. Please inform, yeah, just a response to IVIG is a diagnostic marker of KD.
if the patient is improved with IVIG, what else is needed?
Yes, actually, but we do have IVIG resistance also, but initial response, if it is KD, is there to IVIG, isn't it, Dr. Pratap sir?
Yeah, yes.
Yeah. Uh, can we thank you, Dr. Pratap, for a wonderful talk, and I think we addressed most of the questions. Kawasaki disease will remain an enigma, and there will be atypical cases. And but what's important is that we should have a good coordination. In fact, we all keep discussing cases amongst each other. We have our rheumatology groups, we have our colleagues, and I think the best thing is that we should keep reading, keep learning, and keep discussing. That's the only way forward in Kawasaki disease until we have a proper biomarker or some gold standard.
I request to Preeti ma'am kindly give the final remark.
Thank you very much. It has been such an enlightening discussion, and a big congratulations to the whole group. I'm really impressed, and I think I will be tempted to join every Sunday when you're having this rheumatology class. Thank you so much once again.
Thank you, ma'am. Thank you so
Thank
much.
you. Thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you.
Bye.
Thank you. Thank you, dear Pratap. Okay, bye. Have a night.